Good morning, sir. We'll be starting it shortly, sir.
Okay.
I'm just waiting for the other judges.
Yeah. It's in the same order as participant number 1, 2, 3, and 1, 2, 3, 4, 5, right?
Yes. So first would be the undergraduate category, followed by the postgraduate. So first three numbers are the undergraduates.
Okay. And how much time each person gets to speak?
The presentation is for 5 minutes, sir. After that, there will be a discussion. The discussion time will depend on the judges, sir. Like maximum, we have kept 8 minutes. That is maximum. If you can finish within 5 minutes, it would be good. That is all 4 judges together, 5 minutes or 8 minutes max.
Oh, perfect.
Yes.
No, anyway, I can use the thing, my mobile on the later.
Good morning, sir. We'll be starting shortly, sir. We're just waiting for 2 more judges. Meanwhile, the participants, can you confirm your presence? Tanishk, yeah, I can see Tanishk. Grishma, Anushri, Joshmita,
Yes, ma'am.
Akarshita.
Yes, ma'am.
Akarshita, are you here?
Yes.
Yeah, thank you. Kaushal and team. Kaushal. Just Kaushal and Varsha. Okay. Anuj. Nilesh. Yeah. So only Kaushal and Varsha are not here.
ಐಟಿನವ್ರು ಯಾರಿದ್ದಾರೆ? ಐಟಿದವರು ಬಹುಲಿ ಡಾಕ್ಟರ್ ಅಭಿಷೇಕ್ ನಮ್ಮ ಪೋಸ್ಟ್ ಗ್ರಾಜುಯೇಟ್ ಇದಾರಲ್ಲ ಅವ್ರನ್ನ ಸ್ವಲ್ಪ ಕರೀರಿ.
Good morning, sir. KT, sir.
Yes, sir.
Good morning, sir. KT, sir.
Hi. Morning, Rohit.
All good, sir.
I'm good. So 10 ಗಂಟೆ webinar is something novel. ನಾನು ಇಲ್ಲೇ ಇರ್ತೀನಿ, ಇದು 12 ಗಂಟೆ ತನಕ ಇರುತ್ತೆ, ಅದ್ ನೋಡ್ಕೊಂಡು ಯಾರು ಬೇಡ. ಅವ್ರ ಮಾಯಿಸೋದು ದಿವ್ಯಾ ಮೇಡಮು, ಅಪೇಕ್ಷಾ ಮೇಡಮು, ಯಾಕಂದ್ರೆ ಇವತ್ತು ಜನ ಕಡಿಮೆ ಇದ್ದಾರೆ. ಹಾ, ಅಪೇಕ್ಷಾ ಮೇಡಮ್ ಇಲ್ಲಿರ್ಲಿ, ಅದು ಮುಗಿಸ್ಕೊಂಡು ಮೂರಾದ್ಕೂಡ ಅವರು OPDಗೆ ಹೋಗ್ಲಿ. ಯಾರು ಬೇಡ ನಮ್ಗೆ OPDಗೆ. ಒಟ್ಟಿಗೆ ಮಾಯಾಂಕು ಫಸ್ಟ್ ಹಾಕಿರ್ಲಿ, ಹರ್ಷ ಮೇಡಮ್ ಕೆಳಗಿರ್ಲಿ, ನನ್ಗೆ ಅಭಿಷೇಕ್ ಸರ್ ಬರ್ತಾರೆ, ಯಾರು ಬೇಡ. ಹಾಯ್ ಪಾರ್ಥೋ.
Hi sir, how are you?
Nice to see you, at least by Zoom.
Yeah.
And that too in the morning. How could you catch up this
Yeah.
time?
Yeah.
Working around schedules?
Yes sir, I'm in OPD today.
Okay. So, right.
Judges mother, ಇದು ಅಖಿಲು, ಸೌಜನ್ಯ, ಪಾರ್ಥೋ.
Saujanya, are you around?
A very good morning to all. The only way to discover the limits of possible is to go beyond them into impossible, is a famous quote by Arthur C. Clarke. The word innovation means to introduce something new. This new idea will bring about a change. If there is no change, we don't grow and we don't evolve. We have heard of many innovations that have happened in the past. The trick to innovation is to widen your perspective on what qualifies as new. Innovation 2020 is the first of its kind the department is conducting as an intercollegiate event involving undergraduates as well as postgraduates to showcase their ideas. At the outset, I would like to acknowledge the support of Honorable Chancellor of Yenepoya deemed to be University, Mr. Yenepoya Abdullah Kunni, Honorable Pro-Chancellor, Mr. Mohammad Farad Yenepoya, Honorable Vice-Chancellor, Dr. M. Vijayakumar, Registrar, Dr. K.S. Gangadhar Somayaji, and our beloved Dean, Dr. M.S. Musabba, for guiding us to conduct this event. Today, for the grand finale, we have amidst us a panel of esteemed judges. On behalf of the department, I extend a warm welcome to Mr. Azim Syed Shiraz, Manager at Yenepoya Technology Incubator. Hearty welcome to Dr. Krishna Prasad, who is the head of Pediatric Ophthalmology and Glaucoma Services at the well-renowned M.M. Joshi Eye Institute, Hubli. A cordial welcome to Dr. Parthu Pratim Datta Majumdar, who is the Senior Consultant in the Department of Uvea and Intraocular Inflammation, Shankar Nethralaya, Chennai. I extend a gracious welcome to Dr. Rohit Shetty, who is a cornea refractive surgeon and Vice Chairman of Narayan Nethralaya, Bangalore. I welcome all the participants of today's event. I take this opportunity to welcome all the faculty, postgraduates, and undergraduates for today's grand finale. I hope you will enjoy this event. Have a great day. Before I hand over to Dr. Saujanya, who is the Organizing Secretary of Innovation, we would like to present before you the video messages by the Registrar of Yenepoya deemed to be University and also by the Dean of Yenepoya Medical College. Thank you.
Good morning. I'm very happy to learn that the Department of Ophthalmology is hosting an innovative program basically to look for some innovations from the students both undergraduate level and the postgraduate level who are pursuing ophthalmology. May it be clinical related or research related or anything related to the ophthalmology. They are inviting different ideas from the stakeholders and they are assessing each one of them and they are giving away prizes both at the undergraduate level and the postgraduate level. This is a very unique program, as I know, because this is the first time some department in a medical college is taking this kind of coming out with this kind of different program. Instead of doing a regular CME or any other academic related program, this is a little different and this is quite interesting as well. everyone knows students, they are having lot of ideas, and sometimes those ideas even we may not even think of. So it is an interesting thing to get some ideas out of the students, and if the ideas are really good, we have an incubation center which is actually due for inauguration somewhere in the next month. So maybe we can take those ideas forward through our incubation center. Maybe the student will get sort of a national or international fame as well. I really congratulate the Department of Ophthalmology for having initiated this particular special program. And I know they are actually our neighbors because I am an ENT surgeon, so ophthalmology eyes are always the neighbors for the nose. And in fact, for many years, our OPD was next to the ophthalmology OPD, so I know them very well. They are in fact very active in academic as well as research. Every year they have been organizing different kind of CME programs, undergraduate as well as postgraduate level quiz programs. At least last for 14 years, I know them very well. I congratulate the head of the department, all the faculty. Another thing to be mentioned here is that this is, all ladies department. And I always believe honestly and sincerely that wherever ladies are involved, everything comes out very nicely. That is my personal experience as well. Not because there are ladies in my department, but that is the trend and the tradition everywhere. I congratulate the department for having taken up this initiative. I wish the program all the very best, and I wish all the innovators also all the very best in their future. Thank you.
Good morning. Innovation is an important aspect in the progress of any system, and medical education is not an exceptional to this aspect. This one we are having in the medical education system. We are having the several type of education system like experiential learning, student-centric learning, and participatory learning. All these methods are only in the traditional ways we are teaching them. But to make an innovation in the education system, we have to think out of box, and you have to add the aspects of the students and the ideas of the students. We have to incorporate in delivering the educational aspects. In this aspect, Yenepoya Medical College's ophthalmology department has taken an initiative step to inculcate the views of the students in innovation of education. I congratulate the Department of Ophthalmology of Yenepoya Medical for taking this initiative. I hope all other departments also inculcate this aspect in their curriculum in future. I wish all the best for this innovative system of teaching by taking the out-of-box views from the students, including both UGs and PGs. And I wish all the best for these innovative steps. Thank you.
Thank you, Dr. Vidya. So before moving on to the competition proper, a few general housekeeping rules. So as you've seen and heard, there are judges from a varied background. So there are non-ophthalmologists also in the judging. So please keep your explanations as simple as possible, as non-technical as possible. so that even a person who is not an ophthalmologist can understand your explanation. And when the videos are being played, please keep your microphones and videos off so that there won't be any lag in the video presentation. I would request all, even the judges, please. When the videos are being played, please keep both mic and your videos off. And for the participants, when you're being asked a question, please unmute and keep your video on when you're answering. So the participants have done this before and they know the rules and they know the judging criteria also. During the semi-finals, it was the same criteria. So the same judging criteria will be followed. So everyone is a winner here. All of you who have come to this stage, that means your presentation and your ideas are good. But beware, judge's decision is the final. There is no scope for any argument or bargain. So don't be a sore loser. So we had actually 37 registrations, out of which 19 made it to the semi-finals, and today we have 8 who are going to be present in the finals. So if all are ready, we can start. May the best team win. So this is the order of presentation. First undergraduates, 2, 4, and 7. Then postgraduates, 1, 2, 3, 4, and 8. So judges would have received a scoring sheet which has the numbers already printed on that. So the order of presentation would be the same. So for the discussion, there would be 5 minutes. Maximum would be 8 minutes. We would try to reduce the discussion so that even the last person gets a good amount of time for the discussion so that we won't hurry during the last presentation. So if the first team is ready, we'll be beginning the presentations. So the first team is from the undergraduate. Are there any questions from the judges or the participants? Yes. So we will start then. The first team is Mr. Tanishq BR. He's from Kodagu Institute of Medical Sciences. And his topic is Braille shorthand. So we will see the video now. You have to disconnect. Is the volume in line?
You all know about Braille system. Now in 21st century, what are the problems faced by Braille system? You can name many. So one thing is code is very complex. There is no pictoscopic representation, very limited scanning strategies, and there is a lot of space and bulk requirements, and also reduced speeds. You cannot read fastly, and also another thing is there is writing difficulties. So all these problems are very huge in Braille system. Now for all these problems, 5 problems, 1 solution. Is it Laurier Paris? No, it's shorthand handwriting. We know that there are many advantages of this shorthand handwriting over Braille. So what is it? What are those advantages? In Braille, each dots represent a letter. Each 6 dots comprise to form a letter, but in shorthand, each symbol represents a word. That's a huge speed difference. It's like you had a flash for them to write. So what else can it improve? In shorthand, words are written as they sound. No, there is no confusion in pronunciation. For example, here flower has a different spelling and flower has a different spelling. And every languages can be written in this, as every languages are spoken. And there is no problem in music, so they can learn music very easily. Blind people can learn music very easily, as music is all about sound. No, what is this shorthand? Shorthand is actually a type of writing in which we use strokes, curves to indicate different letters, thereby increasing speed and conciseness. There are a vast variety of shorthand. Some important examples are Gregg, Pittman, Graham, Munson, Lindsley. The process of writing in shorthand is called as stenography. You must be wondering, how can blinds write in shorthand? So here's Robbie with an idea. We see that in this 3D paper, we have touch perception available. You can see that because of thread, you can have touch perceptions of all the squares. For example, this is the left upper corner. A blind person can feel this left upper corner as this has threads in them. So this is the first box, this is the second, and this is third, and so on. The same way, if he wants to write a single word in shorthand, let's take an example of a dog. If he wants to write a dog, so he must feel the left upper corner first. So he feels it very effectively. Then after feeling it, he can fill the box with a written symbol of shorthand. Now in this particular way, you can actually, a blind person can write shorthand very effectively. So we explained about writing, but how will they read? We know that for Braille we use Braille embosser, that is an impact printer. The same way, you can use shorthand symbols to get printed on embossed paper. Some examples are given here. We have other techniques too which can work as a mold for writing. For example, etching technique and also rubber printing. And there are many more to come.
Yeah, it is open for discussion. We can start with Dr. Krishna Prasad with the questions, followed by Dr. Rohit Shetty, followed by Dr. Partho, and last Dr. Asim.
Yeah, I'm audible.
Yes, sir.
Okay, a very good idea. I think it's probably an innovation evolving. I just wanted to ask you one thing, Doctor. What is the normally we actually when we do the with the stylus when we make a braille thing and we read it reverse. Okay, here what are you trying to? You are actually trying to on the paper you're going to write it and read it from the reverse. We could not get that point.
Sir, what I was trying to explain is how can they write? So if they write, they cannot read actually. So that's the one thing that is missing. So if they want to read, they need to actually, we need embossed papers. Just like Braille, we need embossed paper. If at all, there is another option. Like if they want to write in private places, like they want to maintain a diary or any kind of such. So they want to interpret some kind of messages to other persons. So what happens is we can take a thread, we can make a compartment so that they can feel all the boxes. So they will know if they have written in the first box, they will know they have completed it so that they can go to the second box. It's just that there is an improvement towards after Braille. there is some kind of improvement that can be done. And we know that each symbol represents a word over here. Over there, only 6 dots represents a letter. So it will be very fast and also precise.
Yeah, Dr. Rohit.
So Tanishq, a good one. You feel that with this shorthand, you want to bring the shorthand words to Braille? Is that what you're trying to achieve?
Yes, sir.
And what practical difficulties do you encounter in case this goes into a public domain or to the blind? What do you think would be the challenge? To teach
Sir,
them Braille is
the
a
first,
teaching them shorthand again. They have to learn the shorthand again, right?
Yes.
Mobile disconnect.
Hello.
Yeah.
I'm audible now, sir.
Yes,
So
yes.
first thing is, any language is very difficult. If at all I want to learn Kannada or English also, it is very difficult. It's like learning a new language, shorthand also. So basically, if a child wants to learn Braille, he or her will also feel difficulty. So basically, according to we have seen in Da Vinci and all, we have seen that if a language is superior, so is his brain. So if at all, shorthand is a very superior language. If we are able to inculcate this language into that blind person, he'll be able to cope with that environment and difficulties what are faced is. So basically, as it is a new language, so strokes and curves, we need to tell him through skin perception. We have to teach him, like him or her, for that blind person. Initially, there will be too much difficulties, but once it is achieved, I think it will be a miraculous approach.
Thank you.
Dr. Partha?
Hi, Tanishq. Excellent video and excellent idea. But just tell me, how do you want to implement it?
Sir, first thing is, very basic thing is, so if at all a child is coming to us, a parent is coming to us, he or she is asking, my child has become blind, how I want to teach her. So basically, I cannot tell her to emboss in Braille. I cannot tell her. So first thing what she can do is, she can take a piece of paper and with Fevicol and thread, she can write letters like A, B, and with that touch perception, we can make that available. But in shorthand, what I am telling is, see, in longhand, A represents one letter, but in shorthand, one particular symbol represents a word. So that means if at all a baby is trying to feel one particular symbol, in spite of feeling one letter, he or she can learn one word at a particular time. So a piece of paper with one thread, with put that Fevicol and all, as I have shown that embossing thing. So I think that will be an initial step that I can undertake.
So basically, you are suggesting that instead of teaching people Braille letters, teach them shorthand Braille. That's a
shorthand. Yes, sir.
So summary of your innovation is make the people learn shorthand Braille.
Shorthand.
It will reduce the effort of making 6 letters what the Braille contains. Am I right?
Yes, sir. Space will be reduced, speed will be increased, and many things they can do.
They don't have to. The time is reduced by half.
Yes, sir.
Okay,
good. That's
good one.
Okay, that's right. I think just the beginning. I think it can probably be evolve into a much bigger idea and probably a greater breakthrough.
Yes.
Well done, Tanishq.
And just the one suggestion is, apart from the results, whatever results of this innovation, what I would suggest is the Government of India, the ICMR, Department of Science and Technologies are really looking out for these kind of ideas which are going to be funded, because these things needs funding to go on a mass scale. What I would suggest is that take it forward and apply for an ICMR or one of the grants. I think Dr. Saujanya can help you. She's also been a past recipient of some grants, and please apply, because there are a lot of grants for young people who want to do innovation. All the best.
Thank you, sir. Thank you.
Thank you, sir. Dr. Asi. Sorry, Mr. Asim.
Right.
Am I audible?
Yes, sir, you are audible.
Okay. Yeah, very nice concept. Actually, most of the points and questions were already discussed. But my quick question would be, so what do you see here as probably a product or a service? So will it be a service or will it be a product?
Sir, it won't be a product. Sir, it won't be a product.
Okay.
So basically, if it was a product, there would be there won't be any kind of options. It is actually a service. So if at all I am providing a service with embossed paper, if he or she is not satisfied, that blind person is not satisfied, we can actually switch over to etching or rubber printing technique. So I think it would be rather a service. So because blind people needs this, they need to cope with us. So even in note 10 rupees note, we see that there are 15 languages, but there is no language for blind people. So for that, all those for documentation, for money and all, I think it will be service is better idea than a product.
Yeah, excellent. But just a quick suggestion here is
Okay,
very good idea. Probably you can think over a little more, and then you can see what all can come here.
Yes,
So
sir.
when you are saying that there is a paper, a special paper, so
Yes,
probably that could be a product. So if you want to write, if you want to use thread,
Yes,
so probably you can think of some pens which would give you an embossed effect, right? So those kind of things you can think
3D
of.
pen.
Or you can think of probably like in what way it can be implementable, so and also how it can be scaled up and all.
Yes,
So excellent idea, long way to go, but very good actually, nice input. That's all
Thank you.
from us. Thank you.
Saujana, what was his number?
First number, sir.
002.
That is
We are following the
UG 002.
Okay,
002. Tanishq. Thank you, Tanishq. Excellent.
Thank you.
We'll move on to the next presentation. This is by Grishma and Asif Moin. They're from Yenepoya Medical College, and their product is called GlaucoCare. The team number is UG 004.
Glaucoma, the silent thief of vision, is a chronic progressive disease that requires lifelong therapy and review. It is also the leading cause of preventable blindness in the world. Most glaucoma cases are managed with medicines which, if taken regularly, help to lower the intraocular pressure and hence slow down the progression of the disorder and minimize the vision loss. But sadly, poor compliance with therapy leads to treatment failure. Several studies have demonstrated that roughly 50% patients have been found not to be adhering to the medication over 75% of the time. Forgetfulness and difficulty in understanding the drug regimen are the top reasons for poor compliance. But worry no more. We present you with GlaucoCare, your perfect glaucoma companion. If you are a glaucoma patient or have a family member with glaucoma, this is the perfect app for you. It not only acts as a medication reminder, but also helps you track your progression. You can easily manage all your medications using this single app. And in a few steps, you can add your medicines as prescribed by your doctor from our database. Then add the frequency at which the drug has to be taken, and finally a picture of your medicine for easy identification. And voila, you're all set to go. The app will send you reminders to ensure you take your medications on time. You can either confirm your medication or snooze it for later. But if you find yourself hitting the snooze button way too often and eventually forgetting to take your dose, then you may activate the nag mode, wherein you need to take a picture of your medicine in order for the alarm to go off. Never miss a dose or accidentally overdose again with GlaucoCare. It will log your medication history with confirmed and skipped intakes. You can also add your doctor or any family member who will be notified when you frequently miss a dose. It enlists the side effects of the drugs prescribed to you, so you can easily identify the ones not suiting you. You can even set up a reminder for a refill as well as your next follow-up with your doctor. All your records can be printed or shared in PDF format with your doctor. It helps with more accurate drug history and also to identify any drug interactions and to easily prevent them. GlucoCare not only tracks your medications but also maintains a record of your intraocular pressure. If you are using a self-tonometer, you can directly sync your values or else enter them manually on your phone. Now, depending on the intraocular values taken over a period of time at different intervals of the day, GlucoCare will suggest a personalized drug schedule tailor-made just for you according to your diurnal variation of intraocular pressure. This helps in maximizing the efficiency of your drugs. You can also enter your perimetry value, colonoscopy results and optic disc pictures all at one place, so it's easier for your doctor to track your progression and help determine the efficiency of your treatment. It also provides you with helpful personalized tips to help you manage your glaucoma better. Because with GlucoCare, you are not alone.
We can start the discussion. We'll go in the same order. Dr. KP, Dr. Rohit, Partho, and Asim.
I think very interesting. I think again another probably step into the digital dependence, but for a good reason. I'm really quite enthused by the idea because we do have notification in our daily lives. A lot of things we get notified and we act accordingly. We become more lazier and we have now started, given the responsibility to our phones to remind us of our vital, things in the morning and throughout the day. I think this is probably, especially this thing, would work out very well if there are multiple medications. I'm a glaucoma person myself, so I think glaucoma doctor. So patient with multiple medications, the non-compliance is much higher. But probably the only thing, what would be the limitation of this? What do you think would be the limitation of this?
The limitation, what we see is that India is still a progressing country. So not everyone has a smartphone. But as we are seeing the trends, we are assuming by the next decade or so, everyone would have a smartphone. So as of now, it's not 100% user friendly for everyone. But as we are progressing, we shall overcome that limitation.
I think smartphone is no more a limitation. Everyone has a smartphone.
Everyone has, but a laborer
buying a Yenepoya will also buy much before that a better smartphone. The problem is that you get a reminder when you're outside your house and where you're not access. It's not like doing something on yourself. You need the drug in your pocket. So I think if you get a reminder when you've already left home, you're not putting the drops and you're already at work. And if you get a reminder also, it's of no use because you can't go back home and put the drops and come. So probably
the reminder is according to the time that you fix. So you know when your work schedule is and you know when you'll be free and you will have access to your drugs. So it will remind you then according to the time that you fix.
Until you put the drops or snooze it, it will keep reminding. That's what you mean. You can set the frequency also of the reminders.
Yes, sir. You can change the frequency
according to the schedule that you're going to stay at home. Okay.
Yes.
Okay. Nice. I think this probably is very much applicable to our day-to-day life, and that probably will make a big difference to our glaucoma compliance. At least I am very convinced about this particular thing in future. Rohit, sir.
Thank you, sir.
Grishma and team, good work. Two questions I have. One is this? I did see in your last slide you had put some references. There's from a group from Japan, if I'm right, that electronically made. Do they have a same kind of a software already in the world somewhere?
We did a background research on Google Play Store. There's no such app specifically dedicated to glaucoma. There are other apps for medication reminders, but they're just basically like an alarm. But our app is much more. It will also track your records and all, because we know in glaucoma, keeping a track of your progression is also very important for your management. So
Because
that and all is not there in the other apps.
then what did that electronically managed, there was a paper which you had put in your last
It was for the statistics. We read their paper. So mainly it was like, according to their study, 50% over 50% of the patient, they are not compliant for the therapy over 75% of the time. Means that they skip their medications. So that's why we took that line from there. So that's why we put the reference.
And how do you plan to move this forward to an app-based thing? Okay, this is a concept which you have shown. How do you bring it to the app?
So this part, I did talk to some of my engineering friends and all. They were like, app making is nowadays they learn app making, and they were like they can make it user friendly. Which we also went on to search like how much does it cost and all those we checked, and it's not very expensive. So we think we can go forward by making an app with help of our, if we get the help of our at least the incubator which we have in our college, or somewhere we can go forward with this.
My suggestion is that you should again, there are a lot of companies who are making glaucoma medications. They are really having a lot of problems with complaints. So one of the suggestions could be that talk to the companies, like good companies like Alarga and Micro and these companies. And because this will have, and you don't need to have a financial interest, that's your wish. But you can have it, it could not for one particular company. You can, they could probably help you in getting this up and promoting this. That is one way to bring it to the clinical use for everybody to come in. A good one, I think. I second what KP sir said. It's a good one, and this is the need of the hour.
Thank you, sir.
Hi, Girishma and Asif, excellent presentation, and I really like the idea. But there are, I think, 2-3 apps available in the Google Play Store, like eye drop reminder, and I think 1 or 2 app on glaucoma also. So, what is the unique feature of your proposed app?
So we did download all those apps. None of the apps will maintain a record of your intraocular pressures and all. And without you knowing how your disease is progressing, whether it's worsening, whether it's improving, or is it still remaining stationary. So you won't be knowing how effective your treatment is. So this app will help you, it will track your progression and help you know how effective your treatment is. So you can talk to your doctor and get a better treatment option. The second thing is we have also inculcated an intraocular pressure entry. So as we know that our intraocular pressure has a diurnal variation, which is unique for everyone. Mine might peak at an afternoon, yours might peak in the evening. So instead of randomly putting in the drops, if we know when my personal intraocular pressure will peak, so it would be more better if we take the medication at that time of the day. So when you
but it's not
when you
like
add
blood
in
pressure.
your
Who will check your pressure? Who will check your eye pressure? I fully agree with you.
Yes. Nowadays, there are self-tonometers available like eye care and all. If in a country like India, it's still not a very good option. But in developed countries, people do have, like how glaucometers are there in every household. So we are visioning that by a decade, even in India, a lot of people would have access to eye care and self-tonometers. But on the other option is all these glaucoma patients, they are supposed to be having a regular checkup. So when that checkup is there, so doctor himself has to measure the IOP. So they can enter in that values, and based on that data, our app will give a personalized drug schedule, so to maximize the efficiency of the drugs.
Thank you, Grishma. We are crossing the time. We'll move on to the next judge. Sorry to interrupt. Mr. Asim, please.
Yeah. Yeah, good presentation again. Just one quick thought. What do you think would be the compliance to the app itself, given the learning curve? So do you think people will keep on using it? So you're talking about a lot of features, right? So what do you envisage?
I personally am a very I use a lot of apps and I like it because getting reminders, I don't have to put my brain into it. My phone is doing the work for me. If at all there are old people who might find it a bit difficult, but this entering the drug schedule is a one-time thing that they can take help from some other. Then it's more like an alarm. So they just have to click yes, I have taken it, or no, I'll have it in 5 minutes. That is a very easy option. Even an elderly can do. Other than that, those who are very much into their phone, I personally like the apps to do things for me. So I think they would be compliant instead of just
So
relying on
also
your.
one more thing is we have an option of adding a family member or a doctor. So in case if they're snoozing it way too many times, or if they're not taking it, they will get a notification themselves and they can check upon. So it's like a human touch also we have added to the app.
Okay, good. Yeah, another thing is like having a dedicated app for glaucoma care and having probably a general app with a section for glaucoma care. So what do you think would be better? Again, just trying to know your
this
thoughts. What do you
this
feel?
app, if the person, usually these days no one is just suffering from glaucoma, they might also be having other medication. So you can also enter your other medications as well. But the main idea for this is that it helps you track your glaucoma. You need to maintain a good record of how your intraocular pressure is changing, because glaucoma is not a curable disease. It's just
Thank you, Grishma. Thank you. I'll have to cut you short. We are way to cross the time limit. So we'll move on to the next presentation. Sorry for cutting you short. We'll move on to the next presentation. That is by Ms. Anushri Nayak and Ms. Bhavya. They are from Kodagu Institute of Medical Sciences, Sprink and Wink.
Hello everyone, welcome to the world of Sprink and Wink. So you might be wondering, what is this Sprink and Wink? Here we go! This year 2020 has brought a lot of unexpected surprises. Many technical fields have shown a lot of amazing growth in creative ideas and achieved great success. Here, myself Bhavya Kesy and my friend Anushri Nayak, we have done few observations and we would like to share our journey with you all. I would like to ask a question to all the parents. What did your child do in this lockdown, that is Corona time? I'm dead sure 90% of the children used mobiles, laptops, tablets, TV, etc. I'm really scared about those eyes, you see. I know they haven't blinked for a long time. And what about the adults who worked almost 3/4 of the day on computers and work from home? They get stressed so much that they'll forget to blink and the irritation starts. And we the students, we are addicted to mobile phones, doing shopping, playing games, etc. And I guess we all are really stressed. So much of stress and not blinking is not at all good for your eyes. This leads to a condition called as dry eye syndrome, the condition of having dry eyes, and other symptoms includes the irritation, redness, discharge and easy fatigued eyes. And do you know the normal spontaneous blinking rate is between 12 to 15 per minute? So why do we have to blink?
Blink? To look adorable and innocent. No. An average person blinks about 10 to 20 times per minute. Blinking helps spread water, oil, mucus, etc. across our eyes and wipe out dust. However, this is not the only purpose of blinking. Experts notice that the exact moments when we blink are not random. While reading, we tend to blink at the end of sentences. While listening, we blink when speaker takes pauses. Hence, using fMRI scanners, experts observe the brains of some individuals. The analysis showed that while blinking, mental activity dipped in areas which control attention. while the activity spiked in areas called default mode network. This network operates when mind is in a state of wakeful rest. Based on these observations, experts hypothesize that blinking acts as a tiny mental break, thus allowing us to pay more attention when we open our eyes again. What is the...
So here we go with the solution for all these problems. Glasses have always helped us master light. They bend it, they focus it and shield us from it. But these are not your standard glasses. They have a light of their own, a light that connects you to the people you care about, gets you where you need to go and helps you prioritize the things that matter. Technology that's there when you need it and gone when you don't. So hidden by design. So what is the solution? So here we come up with an amazing equipment. So how does it work? When we keep staring while doing work, mainly while using mobiles, laptops, tabs, computers, we forget to blink. As we all know about the concept of think and blink, but we keep ourselves so involved we don't blink. So we have made a sensor which will detect the dryness of our eyes. When the eye moisture decreases and lead to the dryness, our sensor will detect it and make our microspray to sprinkle water on eyelids. As we all know, when anything falls or come close to eyes, we automatically blink. So this involuntary blinking process helps in producing tear film which prevents our eyes from dryness. So indirectly we are making our eyes blink to prevent our eyes getting it dried and to prevent the occurrence of dry eye syndrome. So we are technically working on this and we would like to bring the final product once this abstract gets selected. So thank you everyone for giving us this wonderful opportunity to showcase our talent. Thank you once again.
Over to the judges.
Yeah, very good, Anushri and Bhavya. I think I was just staring at this and I just blinked just now, actually. Now tell me, why do you need to actually assess the dryness of the eye to sprinkle water on the lids? I just presume that it is as simple that you are creating a sensory stimulus for us to blink, which is not happening otherwise. So you're just getting a small water droplets on the lid so that you get a sensory stimulus to blink your eyes. Why should you actually assess the dryness? I think Dr. Rohit Shetty will probably agree with me that it is not very easy to analyze any surface with simple gadgets, and definitely not which can be fitted on a spectacle. So what are your things about, or what do you think about this, Anushri?
So what happens is usually when we look at any device, we don't blink, we keep staring at the device. So what happens is the dryness in our eyes keeps increasing. So we wanted to develop an equipment so that the sensor which we are involving inside the specs will detect those dryness and will sense and will put a microspray on our eyelids so that we blink and we bring up that moisture and we bring out the normal natural process which just enable it a little bit more, because what happens when we stare we forget it to blink, right? It's just a reminder so that you blink because in order to protect the consequences of dry eye syndrome. So it's just like a prevention before anything happens.
Yeah, I do agree. I'm asking, how are you planning to assess the dryness?
Osmolality. So we are thinking about the osmolality measurement, because usually the eye osmolality is around 300 milliosmol per liter.
You're trying to do it in a non-contact method, you mean, without touching the eye surface?
Yeah, yes. So we thought of doing, because if anything is any minute thing to the eye will cause a lot of inflammation and disturbances. So we didn't want to affect the normal eye. So if by from the sensor, if you could detect the water detection of the osmolarity, we could bring this first.
I think I'll pass this to the expert, Dr. Rohit. I think you're walking into a den. Dr. Rohit, you can take over.
I like the way the video was conveyed. But I would give you certain, KP sir is very modest and he's done more work than me. But what I'd like to say is, in the last 20 years, we have not found a machine which can find osmolarity even with the contact method and including having a lab bit, because finding osmolarity in the tears is just impossible. So, I mean, it's not impossible. Nothing is impossible in the world. So I have a fundamental difference that with you, that you can find it with the sensors. You not. See, where I liked your video is, I liked till the where it was giving some feedback and the amount of. So what you could do is, if your sensor can pick up a blink, and the person is not blinking more than is blinked only 4 times. If you can tweak this out, because it's going to be very tough. The osmolarity, tears, and all that is very difficult. Even with with the contact, it's difficult. So I would like you to change your direction a little bit and just say, okay, number of times you blink, like your previous speaker, they look at how much glaucoma pressures. Okay, in a day, you have blinked only average blink of what you did was 4 times a minute. So that you can keep some kind of a sensory loop where it gives you a warning or puts it on your computer saying that you're not blinking enough. The sprinkling water, especially if you're driving and if you're wearing a glass, and suddenly if the water sprinkles, it's not going to be
sorry to interrupt, but and normally we're not sprinkling so much of water. It will be a very minute drop, so that as soon as when there is decreasing of the dryness and it's very minute drops over your lips, so that it not even fall to your eyes.
I understand.
And even
Even if you sit on air, suddenly without knowledge, some gush of air just you get it when you're driving, it still creates a problem. So these are the two things which I would end up with. It's a good concept, but you need to tweak in what are you trying to measure and what you're trying to do. I would allow the next judge to ask you questions.
Dr. Parthu?
Yeah, Anushree and Bhavya, nice presentation. I really liked your video. No question from my side. I think Saujanya will be very happy.
So we can even
Thank you. Mr. Asim, please.
Yeah, hi. Yeah, really good concept actually. Your intention is really good, and probably this is something which is neglected as well. There are experts who would say like best. I would also agree with the previous two judges, especially Dr. Rohit said, right? So why do you need to measure osmolarity? So what you can have is you can have image processing there, just a camera there, which can analyze. Because you know what has to be let's say how many number of times there has to be a blink and all, right? And also the particular design which you're coming up by design itself, it would be applicable only for people who wear specs, right? So what are you going to do with for people who don't wear specs? So have you thought on that?
Yes, sir. It's like we are advising them. So when you're doing any work on the computers, or when you're doing something for a long time work for more than like hours sitting in front of a digital equipment, it's better you wear it so that you blink it. And we have not even thought about osmolarity. We even thought about the lower meniscus level of the tear film. Even that also would have been an effective method.
But
So we had
it's
three
always
ideas in our head.
yeah, that's good, but it's always best to keep things simple. So don't complicate it, because the moment you it's easy to say you would be coming up with a sensor. So but when it comes to a simple sensor wherein you probably just need to measure temperature itself, if you have to build it on your own, it's very complex, right? So try to keep it simple. That's just a suggestion. And don't try to keep it more inclusive of all types of let's say users. So that's another suggestion. So why not, let's say probably if you're using a computer and there is a webcam, so why not, let's say if your technology uses just a camera sensor, so you can probably let's say blink the screen probably rather than trying to spray the water. Anyway, so very good idea, very good potential ahead actually. That's all from my side.
Thank you, Mr. Asim. I think you have got very good suggestions. You can work on it. We'll move on to the next presentation. We have finished the undergraduate category. We'll move on to the postgraduate category. So the first video is by Dr. Tupali Lalitamrita, Dr. M.S. Joshmita, Dr. Aniksha M.N. They are from Sri Ramachandra Institute of Higher Education and Research. They are going to present something about applanation.
Hello everyone. We first year residents of ophthalmology from SRMC came out with an idea to practice applanation tonometry on glove. Due to current pandemic situation, it's been difficult for residents to improve their skills in tonometry. So this method can be useful to get used to applanation tonometry.
Here we used a glove filled with water. You can use air as well. And this is a micro port to support the glove. This setup is fixed on the slit lamp.
Now we use the fluorescent dye to stain the cornea.
Now adjust the slit lamp to do the applanation tonometry. And we use the cobalt blue filter to do this. We prefer a dark room to do this procedure.
Check the Mayas through the eyepiece and keep adjusting the readings.
Over to the judges.
Okay, very nice. I think I'm very happy today that I'm attending this. This is a very simple idea. I think, as you said, simplicity is the very great virtue. I would like to know, did you really do a kind of a series of inflations of the glow by increasing the pressure? Does it correlate with the readings, the change in the readings? Number one. Number two, cornea obviously is a more curved than the glow that you can create. Did you also try inflating the fingertips of the glove? Does it make a difference than the flatter surface of the glove? Did you make all these observations?
Yes, sir. We definitely did that, sir. Amruta would tell about the measurements of the pressure, sir.
Good morning, sir. We actually tried with first the flat surface of the glove only, sir. Then pressures were very high than the normal, which we used to on the normal people, sir. So we then tried even with the only the fingertips of the glove and those things, sir. Still the pressures were not same as the of the people, sir. So now we are thinking of to do it in the future that we'll keep a tube of which will we connected to the glove. So in the tube there will be measurements. So accordingly, if normally 16 mm of Hg if we need it, we had to keep around 217.52 of water in it, so that the pressure matches. So we are trying to keep that appropriate water in it so that we get the pressures which is equivalent to the IOP of normal people, sir. So that both
the IOP, see the IOP measurement depends on the curvature. You got a very flat surface, unlike cornea. So obviously your miles will be much more elongated, and you will have to, the readings will be higher only because not the pressure is inside is high, because the curvature is different. Okay, that is different. What I'm saying is between water and air, what do you prefer to fill the glove with?
I think air was better, sir. Actually, we did this to show the methodology of it, sir. Like in this COVID times, we didn't have patients in the starting 2-3 months of our course, sir. So we couldn't get patients, and then.
No, I think probably you have a better. It's not just the COVID time. It is like a wet lab. It's like a wet lab. Before you do surgery, you just like harness your skills in a wet lab. So it's like a wet lab because applanation tonometry is also an invasive procedure. It's like a surgery.
Yes, sir.
So I don't think it is to do with the pandemic. Yeah, it is to do with getting your skills right. I think excellent idea. Definitely, I think this can go forward. Very well done. Thank you.
Thank you, sir.
Yeah, Dr. Rohit.
Excellent idea. I think the way forward would be like you have created a model, and one of the companies, or if you move on to your incubation center, to create a eye which looks like an eye. And I'm sure you get a lot of eye, so you has like how you have a eye for phacoemulsification and other things. And it's not very difficult to create different intraocular pressures in them, because we're using a syringe, you can actually build in more pressure and less. So then what happens is it becomes very practical. So what happens here is that sometimes you will give different pressures, and you will have a lot of variabilities based on those.
फास्ट ट्रैक में वो आर्टिफिशियल आइज है ना वेट लैब में एक लेके ऊपर
I would suggest that concept is great, but to go into a practical evolution, you need to work with your team. It's not very difficult to build in a globe which can have different pressures, because it's just using water. I think that is only my suggestion. Otherwise, great one. Good one.
Thank you, sir.
Yes, Team SRMC, excellent. I'm really happy to see this video. My only one question I have, so that how you are planning to implement it, how you are going to make it available for everyone.
This is like the basic equipment that we have in the OP itself, sir. Like we have made that these things with the tennis ball as well to see the fundus and all that, sir. Like this is the thing that we did with the tennis ball, sir. So to view the fundus with 78 and 90D and all that. So I think for the first years to practice it, we can just do it with whatever material is available in the OP, sir.
Thank you.
Mr. Asim? Mr. Asim does not have any question for you. Yeah.
Also, did you really check with the? Just wanted to show you. Do you know this plastic eyes that we use for phacoemulsification? Did you try on them?
On these we haven't tried, sir.
I think this would be also a good idea, because they also have, they almost mimic the cornea in terms of their flexibility and the little mechanics. I think probably this would also, just like Dr. Rohit was telling, it would be, the glow would be a crude startup, but this can probably be the refinement. Okay?
Okay, sir.
Good idea.
Thank you, sir.
We'll move on to the next presentation. This is by Dr. Akarshita and Dr. Aishwarya. They are from AJ Institute of Medical Sciences. They have named it as Dexter Sinister.
We say that necessity is mother of all invention. There is no better time than now to come up with new ideas that will help us sail through this pandemic.
Hello, today we present you finding new approaches, navigating the new normal.
There's a better way to do it.
This is Dr. Akarshita.
And this is Dr. Aishwarya
from Dept of Ophthalmology, AJ Institute of Medical Sciences.
Since the declaration of COVID-19 has a public emergency of international concern, the medical fraternity has been dealing with unprecedented problem. We all are in a stage of necessity for a new practice protocol for infection control. So today, we are proposing 3 new ideas. One is loop with shield. The second one is disposable trial frames. The third one is slit lamp shield for patients.
Since the outbreak of COVID pandemic, we have fallen back to torchlight examination for anterior segment evaluation, and visor poses problem for the clear visualization, and hence we've come up with loop with shield. This one helps in screening patients under focal illumination with magnification and minimal contact with instrument. The whole setup can be improved with an addition of 20D lens, displaying the prototype of the image of loop with shield as shown below.
The next one is disposable trial frames. We have made a prototype of a disposable trial frame with sustainable material to help reduce spread of infection through fomite. It's very helpful in camp setting where multiple patients are screened with no time to sanitize instruments.
As we all know, there's already a slit lamp cover that is placing over in front of an objective lens, and this poses main three problems with difficulty to adjust the illumination, difficulty to convey patient command, and a habit of patient that's removing their mask every time they sit puts us all in risk, and hence we've come up with this particular slit lamp cover which is attached to the chin rest and moves along with the same as you move it up and down.
In certain remote areas, camp has been the only access to ophthalmic care. Since COVID-19, conducting camp has posed a problem. Hence, we are suggesting these ideas. Those are mass automated visual screening. We are suggesting an idea where multiple patients can be screened for visual acuity by placing a keyboard in front of the patient, and they are asked to press keys which match the Snellen chart line by line. Patient of 6:9 and 6:6 vision can be screened off, and subject to correction can be done for the rest of the patients.
Coming to screening for vision with modification of Snellen's chart, as shown in the image, we have modified a Snellen's chart with each line represented by a single letter, which helps for a faster screening and also with less confusion and making the whole process easier.
Peak Retina. Talking about the technology which is already there, Peak Retina has served as a helpful tool to document fundoscopic examination of patients in remote area and also help in conduction of virtual camp.
Talking about diaton tonometry, which is a transpalpebral tonometry which reduces contact with the conjunctiva, which is an utmost necessity at the present situation of pandemic, which has no anesthetic usage and less disposable and is as feasible as another tonometer. As we know, the technology has advanced in field of ophthalmology and examination is made easier, and these are some ideas where we ask why not. Why not indirect ophthalmoscope with slit mechanism for comprehensive examination, and why not ocular CT for orbital, apex and surrounding tissue examination?
Ending our presentation with the three main points. One is keeping it short, making sure screening of vision is done in a quicker way by using a single lettered Snellen chart, or minimal contact with patient by using appropriate slit lamp cover as we suggested, and keeping it clean by making sure there's a regular cleaning of instrument or using the disposable frames as we suggested before. Ideas of today is technology of tomorrow. Hope our ideas will kickstart some new technology for a better and a safe future. Thank you.
Over to the judges.
Okay, Akarshita and the team, I think well done. I think this is something very timely for this particular pandemic situation. I think many of the things are easily understandable and can be imagined. I was just want to kind of probe more into your vision checking, especially the remote virtual camps, and having a single letter in the vision chart. How does it actually change anything?
So usually when there's too many letters in the vision chart, in a Snellen's chart, it so happens that the patient do not know where to read it from. Even though you advise them start from one end, even though you point at one thing, they do their own thing. That takes more time in convincing them and giving them the command to as to what we are trying to say. A single letter chart will actually get over all with all these problems that we have. And it also nulls this something called as visual crowding and counter interaction, where when many letters are there, the patient actually gets confused as to what they are reading. So to overcome that, we can use this. It makes it way quicker and less hassle free.
So reduce the examination time, you mean?
Yes, sir. In a camp based, it reduces an examination time.
Okay. And about the virtual camp, you're pressing some button looking at what is that?
Yes, sir. So the thing is, when in a mass camp, and there are a large population to screen for refraction, sir, what we have proposed is there will be a screen which will display the Snellen's chart as we propose, and then there will be a 5 set or a set of keyboards which will correspond to the letters which has been displayed. So when the patient comes, so 5 patients can sit and they can just see whatever they see and they go on pressing the letters. Okay. So it will automatically document all of those things. So this can be quicker, and even the manpower required will be less. Like only a single person can be there, and he'll explain, like they can explain like this is what you're supposed to do, and this will like fasten the process. So people with people with vision who is 6/6 and 6/9 can be just screened off, and other people who really require and refractive correction can be taken up for subject to corrections.
I see. I think no prizes for the fastest finger first, no? Okay, over to Dr. Rohit.
Thanks. Thank you, sir. Aishwarya and Akrashita. Good ones.
Yes, sir.
I have only a few things to ask you. One is, there were too many innovations loaded in one video. So I would see, the question is for a judge now, it is very difficult to pick up which one should we really ask or which one should we. So one of the suggestions for the future is pick up one and keep it for the whole 4 minutes, 5 minutes. That will really be, because what happens is it becomes a little confusing.
Yes,
so my question is about the shield. So how do you want to bring that shield into reality? What difficulties do you think at this point of time you have with the shield?
You mean to say the slit lamp shield or about the loop, sir?
Slit lamp shield. So the one shield right now that is being used is right in front of the objective lens. Every time you see the patient, when you go to take a foreign body or do an applanation tonometry, you have to go through it, across it. It's causing a lot of problem in a day-to-day OPD basis. While that we are saying is attached to the slit lamp where the chin rest is placed. So every time you move up and down, it can be adjusted as well.
So the protection is from the patient side, not from our side, because we have to handle all the instruments and equipment which comes along with the slit lamp. So it is when initially we started using the ones which was placed in front of the objective, it created a lot of problem and annoyance.
I have one suggestion which you can really look into this. See, we a lot of hospitals, including us, have the COVID. We collect the COVID swabs. What happens is, how do they collect? There is a chamber. They put the hand into the glove, a big thing, and it goes and you collect it and do. Why don't you seriously bring in a concept of if you can, using your distance, where you can put your hand into that and you don't need to bypass it. So your hand is inside. It's already fitted into the sheet, and your hand goes in, like how you can see you can see it on internet. There are a lot of things where you can just put your hand, and that hand doing all your 90D, 80D, whatever you want. And even if you can actually open the eyes, do small procedures, so that your hand and everything is not exposed, because your hand is through that sheet.
Exactly.
And you can do a 3D printing of this concept and then start working with it. And the hand thing is a glove. It can always be sterilized. It's a latex material. That would be a nice way of looking this forward. Otherwise, it's a good one. I have no more questions.
Thank you, sir.
Parthu?
Yeah, hi, Akarshita and Aishwarya. Nice presentation. As Dr. Rohit said, no, there are too many things in single presentation, and I got little confused. One thing, why you need the trial frame, disposable trial frame? Any particular reason?
Hello.
So it's mainly because that's one of the instrument which it comes in close contact with patient's eyes. So the thing is, especially when we're doing mass screening or we're doing refraction for a lot of patients, we have to keep cleaning each time for each patient. So to bypass that, we have created a sustainable material which can be used to create this trial frame. So every time it doesn't have to be clean. So this will just bypass all those things, and we can just dispose one and use the other trial frame.
Thank you.
Mr. Rasim?
Thank you, sir.
Yeah, a lot of good ideas in the presentation again. So which one would you want to work on first, probably prioritize?
Firstly, we would really want to work on the slit lamp shield, sir. So that is,
why is it so?
So the main thing is, as we said, it's one of the method protective gear which will make sure that there is no spread of infection from both the ends, from the patient to doctor or doctor to patient, anything. So it's not only for this COVID times I'm talking about, it's everything beyond this COVID times too. It prevents any of the respiratory infection or anything which surpasses this, because as we know that ophthalm evaluation always requires a very close up, examination and everything. That's why we are just suggesting this, so that in future we can use it for any purposes. So it has a protective gear.
It's a permanent thing that can come with the slit lamp. It's not for the time being.
Yeah. Thank you. Thank you very much. Thank you. We'll move on.
Thanks. That's sad.
Sorry, I was on mute. So we'll move on to the next presentation. This is PG003. Dr. Koshal Dani and Dr. Varsha. They are from Arvind Institute, Arvind Eye Hospital. Their presentation is with regard to 90D and 70D.
Clip-on 90 diopter, 78 diopter lens holder. Examination of the fundus is an important part of the ophthalmic evaluation and needs to be done on every patient. Although mandatory, it is often ignored because it's difficult to perform without dilating the patients and also needs meticulous observation of details. Fundus examination can be done by direct ophthalmoscopy, indirect ophthalmoscopy, and slit lamp microscopy using a 90 or 78 diopter lens. Fundus examination is an art which requires practice and is mastered over time. It is often an inciting factor causing anxiety for the beginners in ophthalmology. Direct ophthalmoscopy provides a limited view of the fundus, whereas indirect ophthalmoscopy brings in an additional cost factor of the instrument, is cumbersome for the patient, and cannot be performed without dilating the patients. Indirect ophthalmoscopy also demands a different skill set and experience by the doctor. Fundus examination by 90 or 78 diopter lens can be coupled with routine anterior segment examination without changing the position of the patient. It is an arduous task for the beginners in the early days of residency and may sometimes require 2 to 3 or even 6 months to master the skill. The difficulty lies in coordinating the arm holding the lens and adjusting the mechanical arm of the slit lamp simultaneously at the exact focal length to obtain a clear view of the fundus. This examination needs to be precise, detailed, and has to be completed in a few minutes, as prolonged examination with bright illumination makes the patient uncomfortable. Also, the image may get defocused while adjusting the position of 90 diopter lens, requiring refocusing of the image. Wouldn't it be easier if someone held the lens for us at the exact position, making our task simpler and less time consuming? What if I told you we did it? Yes, using 3D printing technology, we came up with a lens holder which holds the 90 or 78 diopter lens and can also be snugly fitted over the slit lamp. It can be easily slid in for use and slid out when not in use. To arrive at the perfect position to hold the lens, we undertook a series of measurements and finally titrated a specific focal length for the holder, which gives us a perfect view of the fundus without requiring finer movements to focus the image. During our trials, we realized that due to the ideal focal length of this holder, we can still see the fundus details clearly without going close to the patient, as compared to the routine examination, which requires the lens to be in close proximity with the patient's adnexal structures. This causes the lens to be smeared with the natural oils from the eyelashes. Therefore, not only does it come handy for serial documentation in specialties like glaucoma, this holder can also prolong the longevity of the lens. What makes this holder a sui generis accessory is that it can be used for undilated fundus examination with equal ease and also for fundus photography. It can be conveniently used to train ophthalmic assistants, and the images taken with the help of this holder at peripheral vision centers can be uploaded to the base hospital. This is of particular importance in screening patients for slowly progressive diseases with significant visual morbidity like glaucoma, diabetic retinopathy, age-related macular degeneration, and also other fundus pathologies. It can be a cost-effective tool in the developing countries where fundus cameras are a distant dream. With the help of this 3D printed lens holder, we can now sit and examine the fundus hassle-free.
Over to the judges, please.
Yeah, good job, Dr. Dani and team.
Thank you, sir.
What are the downsides of this? Like, what problems did you actually notice during your experimentation?
So the first problem that we noticed was like it took us almost 10-15 days to exactly get to the exact focal length and exact distance at which we can get as good pictures as we do manually. So we had to make almost, I think, 10 to 15, I think 15 such instruments repeatedly by changing the lens, and finally we arrived at an approximate focal length of the device, which we can get the good images. So that was a big challenge, sir. Like the dimensions of
I'm
the.
just talking about during the implementation, not finding the exact focal length. And number two, also another question would be that does it change with the brand of slit lamp? This the particular thing, and also you need to probably flip it to the other side, right? You can't use the same thing and go across the nose. You have to flip it and bring it to this side. No, you have to stick it to the other side every time, right?
Yes, sir. We need those rods in the slit lamp, so it might not be working for this popcorn and all. So we have an updated version, which is an handheld 90D holder, which I have not presented here. I have presented this attached one. So we came up with an handheld holder, which can help us with that attaching it on two different sides. This is one of the first versions.
Okay, and also about the actual problem, when it is actually coming near the eye, when you're holding the lens, the patient is actually reassured because nothing is really jutting into his eye field, no? Yes. But when this is actually being just like an applanation tonometer by prism, when it's coming closer, is there a tendency for the patient to go back or blink? Did you notice this?
Sir, beforehand, we have to counsel the patient that it will stay at a distance of 7-8 centimeters from you. So don't be worried. The usual counseling that we do before gonioscopy or applanation tonometry, don't be afraid. It's easy. It will not touch you. So usually the patient cooperates. And since it is not touching the patient, they are quite comfortable.
Okay. Okay, good one. Dr. Rohit?
I think 2-3 questions which I had to ask, I think Dr. KP sir had already asked. So this is exactly my question. Only one question is, have you tried to take any photos with your phone from this?
Yes, sir. So this especially I will say here, it is very useful in the artificial intelligence topic, which is already undergoing in our institute.
I would have liked here is Dr. Kaushal and Varsha, is that if you had added all this in your video, it would have, all this would have been very interesting, because that would have made it like, like whatever you are answering could have been added in the video. Otherwise, a good one. There's no question.
Yeah, Dr. Parthu?
Yeah, the previous two judges have asked all the questions. Very, very innovative idea. No question from my side.
Srachi?
Yeah, the same here. I think all the questions have been asked. So, yeah, that's all.
Thank you. So
Thank you, sir.
We will move on to the next presentation. So this is by Dr. Anuj. So he's from Yenepoya Medical College. His presentation is about portable slit lamp. I would request all to switch off their videos. Kaushal, if you could switch off your video.
Sure,
And
ma'am.
also unmute. Sorry, mute yourself. Thank you. Over to the judges.
Anuj, I think I wish you had some background noise during the video. I think some explanation probably would be very handy. You are around, Anuj? Hello?
Yes, sir. Yes, sir.
Can you probably lend some voice now? Like, can you very briefly in 1 minute explain exactly what did you show?
Yes, sir.
Where is the innovation point?
Yes, sir. I will show the picture, sir.
No. You can just tell us. No problem.
Sir, it's a portable slit lamp is based on. Am I audible, sir?
Yeah.
The stand is a generic tripod which we can get from anywhere, Amazon, with a tripod head. Sir, the tripod head has an attachment to the tripod as well as another screw which can be attached to the telescopic red cam which comes later. Then there is an attachment as a sleeve attachment through which we can insert either the direct ophthalmoscope or the indirect ophthalmoscope to provide the slit or blue light filters, whatever is required to view for the examination. And then if the counterbalance is provided, if the weight is not balanced, and to prevent it from falling down, sir.
Yeah. What is the actual usage? I mean, we didn't get the whole point.
Sir, the one which we already have, the portable slit lamp, is quite expensive. It's around 1.5 lakhs. And even though it's they said it's portable, because it's quite expensive, it's seen that the use scenarios are quite reduced because of the fear of damage, and it's not really that portable. to bring around towards and different places which we get references. So I thought this will be easily, we can easily attach this and carry around even in our pockets, sir. That was our whole purpose, sir.
So with a mobile adapter, you are planning to devise a portable slit lamp like device, is it?
Yes, sir. And
But where is you're using an ophthalmoscope, no? Direct ophthalmoscope.
Direct ophthalmoscope or indirect, retinoscope.
No. And where is the magnification of the slit lamp?
Magnification is provided by the phone itself, sir.
By the phone itself?
Phone and the next one, sir, the telescopic cam, which can be attached to the phone in the same instrument.
Okay.
So we can adapt different lenses, bulk lenses, and since it's telescopic, we can adjust the focal length, sir.
I think I wish your primary video could have been a little more explanatory, and probably we would have understood it much better with some explanation going with the images, I think.
Yes,
Dr. Rohit?
Thank you, Anuj. I agree with KP sir. One issue with optics is what you write on your format and what you actually use it on a patient is two different things. So what I've understood here is there's a lot of optical drawing and methods, but there's no real prototype yet, right?
No, sir.
So that is a challenge what KP sir was also asking you, because optics is all about coaxial illumination. You are looking at your magnification, your illumination, everything. It's a huge amount of stuff out there. So the big challenge to bring it into real use is how does all this factor play when you use it on a patient? And I agree with KP sir that even though it was on a blueprint innovation, still a lot of today's talks were all blueprint innovations only. But still, if you bring it up, use your voiceover or something, but you answered pretty well. But I would wish that you would have, next time when you submit this somewhere, you use your voiceover so that people understand. Because you understand what you're saying, but we are totally clueless at some point. Okay?
Yes, sir.
Yeah, Anuj, I liked your concept actually. You may have some difficulty while implementing it. I think you need to work on it more. And as the judges said, no, next time you just put voiceover and make it little more illustrative. Thank you.
Yeah. Hi, Anuj.
Yes, sir.
Just one question. So you said that the existing ones which are in the market are around 1.5 lakhs, right?
Yes, sir.
How much do you think would be the cost of this one? Let's say once you...
So the tripod in itself is around 400, sir. Sir, then for the attachments, we need to make 3D printed attachments for to insert the DO or that one. We should, I don't know, sir. It should be
you
because
think
it's
it will be 50% of the current cost, or what do you?
Sir, I already quoted the cost. I expect it to be less than 10,000, sir. I hope, hopefully.
Okay. Sure. Thank you.
Thank you, Anuj. We will move on to the next and the last presentation. This is by Dr. Nilesh Kumar. He is from Lotus Eye Hospital and Institute. His presentation is called DIGS Pro. There is a disclaimer from his side. He has presented this in AIOS. He's not published this particular invention, but he has published and presented initial model of the same invention.
Welcome to the validation of smartphone-based corneal imaging device to classify open and closed-angle glaucoma. I am Dr. Nilesh Kumar. I am a final year resident from India and I am innovator of DIGS Pro.
The person on Galaxy A51, if you could unmute, if you could mute yourself. Galaxy A51, if you could mute yourself.
device that we are going to study today. These are my disclosures. The problem at hand is gonioscopy, which is still considered state of art even after 100 years of its conception. 83% of junior residents are not at all confident in doing gonioscopy, and 25% of the ophthalmologists who perform gonioscopy are not satisfied with their skill, and half of the patients visiting a glaucoma clinic do not get gonioscopic evaluation. So we innovated a smartphone-based gonioimaging technique based on the principle of indirect gonioscopy, and today we are going to validate the device DIGS Pro that works on the same principle and correlate it with slit lamp gonioscopy, that is the gold standard. It was a prospective single mass validation study. A sample size of 222 images were required. A single physician performed the slit lamp gonioscopy and another mass physician performed gonioimaging using DIGS Pro, 4-mirror gonio lens and a smartphone. This is how the image was acquired. A 4-mirror gonio lens was placed in the gonio adapter of the device, was screwed tight, and the smartphone was placed on the device with optics centered with the camera, and the stock camera app of the mobile was used with flash on. Under topical anesthesia, the lens was put on the patient's eye. The patient was asked to look straight. No slit lamp is required, just use the device and the phone. It is well centered. You just click with a flash and the image is captured. So the images obtained were classified in gradable and non-gradable quality, and Schaffer's classification was used to classify open and closed angle. The stats analysis was done to calculate the Cohen's-Kappa coefficient using IBM SPSS version 23. Sequential 280 images were obtained, out of which 250 were of gradable quality and about 44.3% were closed angle on slit lamp gonioscopy. The intra-observer agreement was 0.65 between DIGS Pro and slit lamp gonioscopy, signifying substantial agreement, and intra-observer agreement was 0.82, again a substantial agreement. Gonioscopy is an essential component of glaucoma diagnosis. The current study provides a cost-effective, frugal, innovative technique to screen for open and closed angle glaucoma with a clear, gradable image of 89% obtained. The limitation of the study was that the device is a flash-based diffuse illumination which may induce pupil reconstruction. To conclude, DIGS Pro is a new frugal innovation that can help assess the anterior chamber angle status with good quality images, and the patients can further be counseled and treated, thus lowering the disease burden. Thanks for your kind attention.
Over to the judges.
Yeah. Hi, Nilesh.
Thank you, sir.
Okay, nice to see you back virtually. I mean, do you think this will replace the routine gonioscopy examination in future?
That is the aim, sir. That is the aim. Finally, right now, we are not aiming for that. Right now, we can't say that we will replace that. But the end result, what we aim is to reduce the illumination so that we can have a dim illumination that mimics the slit lamp gonioscopy, and then probably we can claim that we can replace the slit lamp gonioscopy.
Okay, the resolution, what is the resolution like? I mean, since you're taking a picture of all the quadrants and you have to zoom it out to really see the details, does it also make a difference? Like, have you tried different cameras and different pixelations?
Yes, sir. Yes, sir. We have tried the lower end cameras that are 8 megapixels or so. Above 8 megapixels, it will start giving good results. So below that, what we used initially was 1+6. Then we moved back and clicked with the iPhone 5. iPhone 5 gives a clear image, but when we magnify the fine details, they tend to blur out. So above above 8 to 10 megapixels, it starts giving good results.
What about clicking without a flash?
So the initial. So we have tried using external illumination. We had tried, sir, but with external illumination, 4-mirror works because we have a clear space of cornea. So through that, the light goes. But with 3-mirror and 2-mirror, it becomes difficulty because it completely covers the cornea. So that's what we entered this competition. So if we get a grant or something like that, we want to incorporate a small external illumination inside the device so that in a closed compartment we have a controlled illumination.
Okay. And it's the point of contact is the same as any gonioscope. No, it doesn't increase because of this gadget.
No, sir. It's normal gonio lens. Whatever we use, same.
The contact point is the same. The rest
Yes.
all the okay.
Yes.
Okay. I think this definitely interests me. I think it is going to probably open up a new vista in the because our whole problem is the gonioscopy for postgraduates. I think this digital innovation can probably makes a lot of things easier for the patient also. Yeah.
Thank you, sir.
That white thing which is there around the gonioscope lens, does it touch any part of the eye?
No, sir. It doesn't touch any part of the eye, sir. We have calibrated so that it is just on the rim, the gonio rim. It just goes, sir. I have the device here, so the whole gonio is out, and only this part is it holds the lens, sir. So it is quite away. It is not even touching the brow.
Okay, that's it. Thank you.
Thank you, sir.
And hi, Nilesh. Thanks. Excellent presentation and excellent device. So if I ask you to pick up one downside or disadvantage of this device, hello?
Yes, sir.
Yeah. So what is that?
Theoretically, sir, the practical solution problem what we face is the flash. That is the practical problem. Theoretically, we have found because once we got the good correlation between the slit lamp and the device, so we worked backward and we found out that the pupillary lag, that once we shown the light and then the pupil constriction, it takes 0.1 to 0.2 seconds, sir. And the whole the image that it takes is 1 by 100, so it's 0.01 second it takes in that amount it takes the image. So theoretically we can still say that it won't, but practically, sir, nobody is going to believe that with so much of flash it won't induce a pupillary constriction. So that's what we want to improve. The next version we want to improve on that, sir.
Thank you.
Thank you, sir.
Mr. Asim?
No questions from my side. Thank you.
So we have come to the end of the presentations. I would request all the judges to click on the join break room icon. And I would request all the participants to stay back. We'll be just showing a small video about Yenepoya Technology Incubator, so you can get an idea about it. So after a lot of discussion, the judges have come to a final decision. Before announcing the winners, I would like to thank Yenepoya Dept of University for providing us this opportunity. I would also like to thank our esteemed judges and who have given us awesome feedback. It was very valuable feedback. So thank you, sirs. And in spite of all their busy schedule, they have taken time to participate in this program. I would also like to thank our participants who have come up with such great ideas. Our postgraduates and STA, Mrs. Gayatri, who has been great help. Our IT department, Mr. Karkera, Mr. Dinesh, and Mr. Deepak, who have been supporting us thoroughly during this endeavor. Our photography department. I would like to thank my teammates, that is Dr. Rashmi Jain and Dr. Sheetal Saur, who has been a great source of support and encouragement during the whole process of this program. And a big thank you from all of us at Yenov. And now I would like to announce the winners. If Dr. KP would like to announce the winners. Sir, you're on mute, sir. You're on mute.
No, Sarjonia, I would like to hear it from you. You are the, I know, it should come from you. I'll be here.
Okay, so thank you. So, okay, this was, I missed this picture. This is Dr. Rashmi and Dr. Sheetal. This is Team Yen-novation. So, the UG category winner is Glaucocare, UG 004, Dr. Grishma Gopan and Mr. Asif Moin. Very well done. And for the PG category, it was a unanimous decision. It was PG 008, that is Dr. Nilesh Kumar.
Thank you, sir. Thank you, ma'am. Thank you so much.
So we have two more winners. There are two out of the box ideas here. So this is team UG 002, that is Braille Shorthand, Mr. Tanishq PR. And in the PG category, PG 001, that is the team from SRMC. So you both get an opportunity to collaborate with the Yenepoya Technology Incubator. The terms of this would be discussed on a mutual basis. So it should be a mutually agreeable terms and condition. I will connect you to Mr. Rasim and you could take this idea forward. Thank you once again. Before leaving, could we have a virtual photograph? If you could all on your cameras, please. If everyone could on their cameras. Team from AJ, Dexter Sinister, Aniksha, and Varsha. I have promised, sir, that I'll finish by 12. So please, if you could on your cameras, please. Yes, Vidya ma'am. Team Dexter Sinister. Okay, I guess they are not there. So we'll go ahead and take a picture. The IT team, if you could take the picture. Everyone, please smile. Thank you. Thank you. Thank you all. Have a great day. Bye-bye.
Thank you. All the best.
Thank you. Thank you, ma'am.
Thank you, ma'am. Thank you, sir.
Thank you, ma'am.
Thank you, sir.
Thank you, sir.
Thank you. Thank you all. Thank you.